interpersonal interactions in chronic pain. And this is a talk I'll be giving at the British Neuroscience Association Festival of Neuroscience on Tuesday as part of a symposium on chronic pain. So it's kind of an interdisciplinary symposium. It includes everything from mouse models to electroencephalography and long COVID to my social neuroscience stuff at the end. So I'm really grateful I get the opportunity to present it to you first. I've only got 20 minutes in that presentation, but I've made this one a bit longer. So there was more I really wanted to talk about. So hopefully it's okay to give you the slightly extended version. Yeah, it is a brand new talk, so it does include some unpublished data of 2 brand new studies that we're currently analysing. So I would just ask you to not photograph the slides or share those slides because it's work in progress. But excitingly, it is work in progress, so hopefully it will be new to everybody. All right, I'm going to share my screen. Just bear with me. Can everybody see that?
Yes.
Okay, perfect. I'm no longer able to see anybody now. Apologies. So if you do have any questions, please just shout and then I will know. Right, let me just minimize this. Here we go.
It's sharing it, you know, so you can see all your slides along the side.
Yes, I'm just putting it into presenter. Is that okay?
Perfect.
Brilliant. Okay. Yeah, so today I will be focusing on 2 types of social interactions that are particularly salient in the experience of pain. Those interactions that we have with our loved ones and those that we have with our healthcare professionals. Before I start, I just wanted to, this is part of the BNA slide deck, but I wanted to show you as well that we've been doing quite a lot of public engagement work around the British Neuroscience Association Festival of Neuroscience. And this was an event that 3 colleagues and I did at the beginning of April up at the Shakespeare North Playhouse, where we did an interactive session looking at how our brains process touch and pain. And we did a lovely turnout for people who were really interested in learning more about everything from the periphery to the cortex and how we experience pain. So that was really fun, and hopefully something we could do a bit more of in the future. We got some lovely feedback, and Joe from the Pain Relief Foundation was there as well. Okay, so the symposium aims, although not relevant for this talk, I've still included them because they do scaffold the session. So the symposium on Tuesday will really aim to showcase some of the interdisciplinary methods in chronic pain. And this is where I'm going to come in and look at social neuroscience theories and paradigms and how they can be applied to understanding chronic pain. Another aim of our symposium is to inspire neuroscience researchers, but I would say anybody who does research, to embrace complexity. And this is something that I sort of find especially fascinating about this topic, is that nothing really is more complex than our social environment, and trying to boil that down into something you can study in a systematic way is both challenging and really exciting. That's what I love about my work. So I will be presenting quite a lot of complexity, but hopefully not putting anybody off. And then lastly, the third symposium aim is to give some practical examples of how we can integrate patient experiences into research for better clinical outcomes. So throughout this talk, we do a lot of public and patient involvement work. A lot of it is championed by Maria, who presented last month. So throughout the studies that I present, I'll just show you how we involved patients in everything from the design to the materials, and then hopefully soon in the analysis stage as well. Okay, so I've given this slide before, I'm sure, and I always like to start off with highlighting the importance of social connection. Really, as we all know, we rely on our caregivers early in life to keep us alive, to clothe us, feed us, soothe us, protect us from harm. And so our caregivers' expectations and our responses to our physiological states contribute to how we learn about regulating our bodily states, including pain, basically from the minute that we're born. So our pain experience is social from the word go. And there is a nice social neuroscience theory that emphasizes the importance of others in all experience, but also pain experience. And this is social baseline theory. It's well worth a read. It draws on attachment theory and neuroscientific principles of how the brain works, to really put forward the idea that the first and most powerful approach the brain has to regulating affect is via social proximity and interaction. And the baseline comes from the fact that really our brains have evolved to the default position that we should regulate our emotional states through others. That is the baseline assumption that others will help us to regulate our emotional states. And if we're in the absence of conspecific, so if we're on our own, then that increases threat. It increases the burden in terms of on our cognitive resources, on assessing risks, on dealing with stresses, and all the rest of it. So the idea behind that really is that others can help us by sharing the load in terms of, if we apply it to pain, really in terms of informational support, in terms of emotional support and all the rest of it, but also in terms of risk assessment as well. So scanning the environment for risks. And there's a nice study that's not related to pain, but illustrates this example, that people actually perceive the gradient of a hill as less steep when they're in the presence of supportive others than when they're compared to when they're alone. So this theory is something I'd like you to just keep in mind throughout the talk. It's the idea that really we have evolved to emotionally regulate through others, and then when we're on our own, that defies this baseline assumption. Now, interestingly, although we know that about the brain, and there's a lot of evidence to support that, when we look at earlier neuroscientific articles on pain perception and the neural signature of pain perception, the social context is actually largely missing. So this is from a paper by Irene Tracy and a colleague in 2007. And you can see that context does feature, but the social context is completely missing from this initial neuroscientific picture. So this was the kind of state of play when I first came to this area. Luckily now we have a lot more evidence that social context and social interactions directly shape our pain experience at a self-report and also at a neural level. Okay, so when we first came to this kind of research field, and we wanted to say, hey, what about the social factors? How do they influence pain? Because, of course, biopsychosocial models have emphasized the role of social factors for quite a while, but there was very little kind of experimental research looking at the causal role that social environment can play in influencing pain. And what I did 12 years ago now is initially review the experimental and neuroscientific literature that was available that kind of systematically varied an aspect of the social interaction. This was dyadic, so it's important to note that, of course, you can look at this at different levels from kind of interpersonal to societal. But I focused mainly on the interpersonal dyadic level, and that's what I'll be talking about today. So what we did was reviewed the literature in the field to see, what's the evidence for a causal role of social interactions in impacting pain? And B, can we come up with a neuroscience-informed model, a kind of a mechanistic model of how that might work? And so this is a bit of a complicated image, and I'm only going to refer to bits of it. But essentially, we conceptualize this in terms of predictive coding principles. So the idea that our brains are prediction machines and that we're constantly matching sensory input or incoming information with our top-down expectations to ultimately determine what we feel, what we think is going to happen. And so in pain, these are well-established models. So we predict how much pain we're going to be in, we get some sensory input, and we update our predictions, roughly speaking. And what we said was that social interactions can directly impact on that prediction kind of loop. And in the second step, which is a critical one here, we said that how much they do that, or how kind of precise our social interactions are in shaping pain, is also tied to how we perceive them in the first place. So this is where internal models of relating can come in. So if I've got a insecure attachment style and I, for example, have experienced that others are not generally very responsive or reliable, then I might place less weight on information coming from those social agents compared to my own experience, for example. And that weight that I then place on, for example, somebody telling me how much pain relief I should get from a painkiller, or somebody providing some empathic comments, the weight that I place on that in impacting my own kind of predictions about my pain will vary as a function of how I perceive these social relationships. So it is a bit of a complicated model. I will refer back to it, but ideally it's a way of organizing the neuroscientific literature and showing how these kind of causal effects that social interaction can have on pain. And in acute pain, there's quite a lot of evidence for this. We've kind of gathered some evidence for this model now across the years. This was from an experiment where we systematically varied the trustworthiness of somebody who administered a cold pressor task to our participants. This wasn't that difficult to do, actually. We gave people statements about the person. So we kind of said, we've asked participants to provide feedback. This is a medical student who wants to get better at kind of bedside manner. So at the end, we'll ask you for some feedback about how you found them. And then we gave participants that feedback, and it was either engineered to be very positive, so-and-so really cared about me. She was a reliable and consistent person, compared to be honest, she didn't come across as a particularly reliable or consistent person. And people really did believe that manipulation. Then we had that person give them a piece of advice about how long they thought they would be able to last on an upcoming cold pressor trial. And what we found was that when people had that higher trustworthiness encounter, they took that advice on board more, and that actually led to greater pain tolerance on a later trial. So that's some evidence that, the kind of the way that the social agent is perceived directly impacts how our predictions are updated. In this case, our prediction about how painful a cold pressor is going to be, and that then has a direct impact on how much pain is actually perceived. So this is all in acute pain, and of course we're talking about chronic pain today. Just to say, I've got a new PhD student starting in June who will be delving into this a little bit more in relation to acute pain. But diving into chronic pain then, and looking at the importance of social interactions there, together with Katie Heron and some colleagues at Liverpool, we've just done a evidence synthesis of the qualitative literature, looking specifically at how people live well with chronic pain. And these social interactions came out as one really important factor. So that perceiving love, support, and connections with others helps people to thrive while living with chronic pain. So that article is under review at the moment. Well, we're revising the revision. Anyway, it's going to go back to the journal, so hopefully stay tuned for that coming out relatively soon. So qualitatively, we have a lot of evidence to support that social interactions are really important for the experience of pain and for people's ability to live well with pain. Okay, so the new data I'm going to be sharing today, I've got 3 strands of kind of ongoing work looking at the most salient interpersonal interaction partners in the pain experience, so focusing on loved ones and healthcare professionals. Of course, there are plenty of other, for example, somebody's employer, definitely another salient interpersonal interaction partner, but these 2 are the ones I'm focusing on here. And I'm going to present you these 3 kind of strands. The first is going to be familiar to those of you who were there for Maria's talk last month, where we're looking at how people with chronic pain decode or interpret cues from healthcare professionals that relate to empathy. The second is, so we're moving from kind of distal to proximal. So the second, we'll look at how people with chronic pain, how their personal space boundaries are influenced by different factors. And in the third section, if we have time, I'll talk to you about even more proximally effects of soothing touch on pain experience. Okay, so we'll start with healthcare encounters. This is a bit of a recap on Maria's data, but hopefully it can't hurt to consolidate things a little bit. And just bringing it back to social neuroscience, because that is the point of the talk, we always start with a kind of neuroscientific understanding of how these complex social constructs work. So in the case of empathy, there's plenty of neuroscientific evidence to show that empathy has these 3 dissociable components. They involve a cognitive component, which is understanding how somebody is feeling, an affective component, which is kind of the ability to share that state or to at least feel what that other person's feeling, and then a behavioral component, which is displaying compassion, communicating pro-social concern. And these processes are not automatic. They can be voluntarily up or down regulated, depending on the context, depending on the person. So this is a really useful kind of framework, and one where neuroscientific insights can really help us to understand quite a complicated social construct. Now, we know that healthcare professionals can perceive people with fibromyalgia in particular as slightly more difficult than other chronic pain patients. So, for example, people with rheumatoid arthritis, and that also empathic behavior is significantly lower for people without visible signs of illness. And these 2 factors were why in Maria's PhD we have focused specifically on fibromyalgia as the chronic health a chronic pain condition of interest, though I'm sure some of these things that we'll be discussing are salient for other chronic pain groups as well. This is a plug at the BNA because Maria will have a poster there. So if you are at the BNA next week, please go and have a look at that. And essentially, we know that patients with fibromyalgia and with chronic pain more generally can report feeling disappointed, ignored, or powerless in a system in relation to healthcare professionals and the system. So we know they do get bounced around a lot. There's quite variable experiences in healthcare. And it's also often associated with early adverse childhood experiences and trauma. So there's a good meta-analysis that really shows the kind of the sort of lifetime stressors and adverse childhood experience impact on fibromyalgia. And if we relate this back to my model, you can see that this is targeting sort of how the social interaction partner themselves is perceived. So we've got the experiences people have made in a pain context. And here, instead of thinking about attachment, well, we can still think about attachment styles, to be honest, but we can think about internal models of how we relate to others. And those two things will interact to determine how salient or not that person is in defining our pain experience. So we wanted to ask, how are ambiguous social emotional cues interpreted in healthcare encounters? In short, how do people with fibromyalgia kind of see whether or not a healthcare professional is trying to be empathic or not? And this is quite well explored in different fields, and it's something that has been looked at a lot in the cognitive bias literature in relation to anxiety and depression in particular. So people who are more anxious or more depressed, also people who worry and ruminate more, tend to jump to negative conclusions in the face of relatively ambiguous information. So a classic example is if you're walking along the street and you see your friend across the street and you wave at them and they don't wave back. That in itself is an ambiguous situation, and you can decode that in a positive way, or a benign way, so they didn't see you, or in a more negative way, that they were purposefully ignoring you. And so what that tells us is, in the face of ambiguity, how do we tend to resolve that? How do we tend to interpret that? It's in short, does that, and so do these sort of expectations around that, then how do they impact on our pain experience? So in chronic pain, there is some evidence for a negative interpretation bias, so a tendency to jump to more negative conclusions. But interestingly, this has only really been explored in relation to pain or illness-related signals. So people with chronic pain might interpret fairly ambiguous bodily signals as threatening or painful. But it's rarely, if at all, been extended to the social environment. I'm only aware of one study in adolescents that kind of looked at social rejection sensitivity in people with chronic pain. So given that we know that the social environment plays such an important role, we wanted to look at interpreting these sort of social cues. So Maria collected data from 170 participants so far. 66 have fibromyalgia, 78 don't have any kind of pain, and we are currently recruiting a third group of people with chronic pain that is not fibromyalgia, to see whether any results that we get are fibromyalgia specific or do apply to people with chronic pain. We co-produced this new interpretation bias task together with our public and patient involvement group, and we used a format that's commonly used in the anxiety and depression literature, which is to show short scenarios, a couple of sentences, that then end in ambiguity, and that ambiguity can be resolved in a number of ways. And you saw these scenarios in Maria's talk, so I'm not going to spend too long on them. But essentially, they give a bit of context. So you're in the hospital or you're waiting for an appointment with a doctor. And then the key ambiguity in the first one here, you see the doctor's facial expression change. This is a really nice one because it could mean anything. It's very ambiguous. And really what you can see is people's prior expectations as to what that means come through. So in a positive sense, this can mean, the facial expression could change to one of concern. It could change to a judgy or negative one. On the right-hand side here, you can see the ambiguity is the doctor giving an opinion or asking follow-up questions after nearly every point. Again, on the face of it, that's not positive or negative, but you can bring your own previous expectations, prior expectations to bear on that and interpret that as being trying to understand your situation by asking kind of questions to gain a better understanding, or kind of questioning or doubting your experience. So all the participants rated 15 scenarios that were co-produced, and they just said how likely, they did likelihood rating, that they would kind of interpret this situation in that way. And what we found really quickly, again, because you saw this last month, is that patients with fibromyalgia did significantly, so rated these negative interpretations as significantly more likely compared to our pain-free comparison participants. And I want to emphasize this was controlling for self-reported anxiety and depression. So this is something that is tied to pain and not to negative mood or anxiety that's associated with being in pain. And we also gave people self-report questionnaires about how empathic they rate their healthcare providers to be. And you can see, which is sort of a validation for our new measure, that more positive interpretations, so that, or should I say, a greater likelihood rating for the positive interpretation were linked to more positive perceptions of empathy from healthcare professionals. So that's a bit of kind of convergent validity, but nice to see. Now, that's the top part of the model, right? How are the social interactions themselves perceived? How are these empathic cues or potentially empathic cues decoded? And the next part of the model is, of course, seeing about how that would impact people's pain directly. And this is Maria's next study. So stay tuned, and she will be back to looking at, to present when we look at systematically varying empathic cues, does that impact directly people's distress and also their pain? So we will find out about that. And at this point, this is obviously behavioral data. We didn't actually have any neuroimaging in this, but I wanted to show you what the next step could be if we took a social neuroscience perspective on this. And in particular, we've done this with worry, and we can ask ourselves, so at what point when we encounter ambiguity do we jump to these conclusions? Are they fairly automatic, or do we actually weigh up the different possible interpretations and then pick one? And this is where neuroimaging can really help us, and in particular, electroencephalography. So EEG has a really good temporal resolution and can tell us kind of the different steps on the way to making a self-report rating, for example. And one way that we've done this in relation to worry is we've looked at an event-related potential called the N400. And this is something that's often used in language research, and it indexes violation of expectancy. So if you see the sentence, I trim my beard, and if you see the word eggs instead of the word mustache, you'll have a nice N400, because that's not what you expected. That's not how you expected that sentence to end. And my PhD student at the time, Yeshun, made up lots of statements relating to worry. So, for example, we had, as you give a speech, you see a person in the crowd smiling, which means that your speech is funny or stupid. And the idea here is that if you've got a negative interpretation bias, if your tendency is to jump to negative conclusions, then you should find the positive interpretations violating your expectation. So you're expecting the negative, you should get a nice big N400 for the positive. And vice versa. If you've got a more positive interpretation bias, then the negative ending will surprise you. So the reason I'm showing you this is because it links back directly to the coding model I was showing you, because it essentially indexes prediction error. How much are your predictions supported, or how much surprise are they is generated when you see something different. And this is from a study that we did with worriers. And what you can see, if you look at the dashed line here, this is the N400 to the negative. And you can see that people who don't tend to worry very much, they show a greater kind of surprise or violation of expectancy when they see the negative ending, compared to our high worry group, who essentially expect the negative ending. But you can see that in terms of the benign, there's not actually much of a difference. So it's really important to think that benign is not necessarily the opposite of negative. It's a bit more complicated than that. And different studies will give you different sort of findings regarding whether it's always a more negative interpretation bias, or actually the absence of a sort of positive bias. So I'll leave that there, but I wanted to show you that because that's a way in which you could adapt social neuroscience paradigms to chronic pain. And it would be really interesting to do this kind of a study with people with chronic pain. Okay, just because I promised it, a bit on our public and patient involvement for this, and also Maria's other study. These are some of the things that we've done across months and months. So we have a mix of in-person accessible venues and online events where we discuss initial ideas. co-create and refine the materials. We also have some separate meetings with healthcare professionals. We don't tend to mix our patients and our healthcare professionals, so we keep those meetings fairly separate. And then we curate a newsletter event, which you can see is just a Microsoft Sway platform that Maria keeps beautifully up to date. And that's a newsletter that goes out to our group to keep everybody in the loop in between. Okay, we're going to shift gears a little bit. This is my slight worry about this talk, was it's a bit disjointed in terms of the different strands, but I'm trying to give you a bit of a flavour of different things that we can study through a social neuroscientific lens. So moving from how we interpret verbal statements or how people and facial expressions, or how people kind of react to us in an interpersonal space, we've, in a different strand of research that's being funded by the Pain Relief Foundation, looked at people's sense of personal space. So we all have a preferred comfort distance. This is the idea when people are in our personal space. I mean, anyone who's been on a tube in London will feel this viscerally. But we know that these personal space boundaries are malleable. They're not fixed, and they're affected in particular by ambiguous or socially threatening contexts. So, for example, this study by Vagnoni and colleagues showed that when we've listened to an aggressive conversation about two agents that have nothing to do with us, but just listening to that aggressive conversation will expand our personal space boundaries. So, I mean, we don't let people approach to us as closely. And in cognitive neuroscience, this personal space idea is called peripersonal space, which is the multisensory representation of the space around our bodies. And this has been explored in chronic pain quite a lot. So, for example, in CRPS, there's a lot of research looking at this kind of sense of the multisensory representation, for example, of a limb in space. But again, critically, very rarely been investigated with social stimuli or in any kind of a relational context. And if we go back to the model, this is really at the interface here, because how we feel, so how our pain is going, will influence, according to my hypotheses anyway, how close we let people approach to us. And again, who we let approach to us will conversely sort of impact how uncomfortable we feel. So this model is nice because it really is dynamic and interactive, and it acknowledges the sort of cyclical nature of things. So there is one previous study that looked at chronic low back pain, and they had a person approaching them in 3D space and found that people with chronic low back pain maintained a greater distance from that person. But that was with a stranger, and it didn't look at relational context. So what if that's somebody's loved one, for example? And it is one study. So what we've done in the study I'm about to show you is used a stop distance paradigm where people listen to footsteps approaching, and the idea is that they stop the recording when those footsteps become uncomfortably close. We've also extended that, so most paradigms just use the stopping time as their outcome measure, but we've also asked people, well, how safe, how threatened, and how comfortable did you feel at the point at which you finished the recording? So this is a study that we've just completed. We collected data from 49 people with chronic primary pain. So we excluded people with cancer-related pain, for example, because there are just lots of other factors at play. And we also recruited 48 pain-free comparison participants. And we asked them all to imagine either a stranger or a loved one, or they heard a ball, because the problem with social research is always that people can always say, well, come and say, well, is this really social, or would this just apply to any kind of stimulus? So we included a non-social stimulus condition, which was a ball bouncing at a steady pace towards the listener. And I've got this is one of the clips, so you can hear what that sounded like for participants. Just gets louder and louder until you stop the recording, and it stops a meter before the listener. So I don't know who you imagined while you were listening to that. We've had, starting again. We've had our public and patient involvement group try that out as well, and the feedback was that it is quite aversive, I think. But here, of course, we did have people imagining their loved one as well. So interestingly, we've not found any effect of the pain status. So we found an effect of the condition of who you imagined or who they imagined, but not chronic pain versus pain-free. So everybody let their loved one approach closest, followed by the ball, followed by a stranger. And in terms of the subjective threat rating, everybody found the loved one least threatening, followed by the ball, followed by the stranger. So perhaps that doesn't sound very, perhaps that sounds quite intuitive, but I find it's not really been studied at all. So this is nice evidence to kind of support that doesn't seem to be an impact of pain status itself on this kind of idea of personal space boundaries. You can see that although this isn't significant, our chronic pain group did let people approach didn't let people approach us closely and did find it slightly more threatening, but that's not a significant difference. However, when you look in the chronic pain group, then longer duration of pain, so we asked how long has your chronic pain gone on for, but not the level of pain severity or interference, was associated with maintaining a greater preferred distance across any type of approacher. So this is a cross-sectional study, but it would be really useful to look longitudinally at whether there's a sort of an eroding effect over time that people will maintain larger personal boundaries. Now, what was nice about this study as well, I know I'll say it myself, but what I think is really useful to do is we asked people who they were thinking of when they completed it. And we've gotten some really fascinating qualitative insights that we're hoping to analyse as well. And I just wanted to give you a little flavour of the kinds of things people said. So for the stranger, people said things like, I felt on edge, who is this person and what do they want? I didn't feel safe. This is for people in the pain group. They felt like they were getting too close to me. For the partner one, I'm showing you these because it shows that we need to go in a bit more detail to see what's going on, because we had people saying things like, I imagined my partner coming over to me and giving me a hug to reassure me. But we also had, I imagined my partner walking towards me, but I had the feeling she might have been angry with me. So this is a bit of a crossover with the interpretation bias study, and it would be really interesting to delve into that in more detail, because these two people will probably have differed on how close they let that person approach. This was the ball, and so you can see that people had predictions around being hit by the ball, which is interesting. So of course, if you are in pain, you have a heightened sort of vigilance to not injuring yourself further. So I think it's really good that we included the ball condition, and I would urge people to do that in the future. So this is, I said, in prep, hot off the press data, or hot off the Excel spreadsheet data, that we're exploring in a bit more detail. Now, the last few minutes, just because to make another point about how social neuroscience can be useful in studying these sorts of things, is I wanted to just spend the last few minutes talking to you about touch. I won't do this in a lot of detail because I think last January I was here and gave you a kind of a longer version of my touch research. But I think it lends itself nicely to the topic of the talk, but also to this idea of going from kind of more distal, kind of verbal social cues to personal space boundary to, okay, now someone is in my personal space and providing some touch. And here we're moving seamlessly. So we started with healthcare professionals, moved to strangers and loved ones, and here we're firmly in the loved one realm. So as a very brief recap, the kind of touch I look at is not discriminative touch. So touching a surface in order to see how hot or cold it is, or rough or smooth, or other things that we do to when we talk about discriminative touch. What I'm talking about here is effective interpersonal touch, touch that's meant to communicate some kind of a pro-social intention. And in social neuroscience, that kind of a touch is quite well characterized. So it's this kind of slow, gentle, soothing, stroking touch we're talking about that can be contrasted with a faster, more effectively neutral touch. And then underpinning physiology is also well characterized now. So there's a specific type of unmyelinated C-tactile afferent fiber that underpins that kind of gentle, slow touch. This is a slow, dynamic, caress-like touch, and it's particularly important in initiating and then maintaining social bonds. So it comes under lots of different names. If you read the literature, you'll see all of these terms. They don't actually all mean exactly the same thing, but they are sometimes used interchangeably. And this kind of slow, gentle, soothing touch is used spontaneously by mums stroking their babies, and also in adult intimate interactions. So if you just say to someone, stroke your baby as you usually would, they'll be using these what we call CT optimal speeds that activate these CT afferent fibers that are encoded as feeling pleasant. Okay, this is a really complicated brain slide. I'm not entirely sure I will actually discuss it at length, but all I want to say is that we put forward a model, again, a neuroscience of form model of how that kind of gentle, effective touch um, can help us to achieve allostasis. So essentially, or help us with our allostasis. So essentially, how we maintain our physiological stability in an ever-changing environment. I think that's actually all I'm going to say about that, because I think it makes more sense in the BNA context. But I'm happy to talk about it more in the questions. So we've very briefly we've shown that this kind of effective touch has a pain modulatory effect in acute pain. This was in couples where one member of the couple administered slow, gentle, soothing stroke touch to their partner, or that faster, non-affective touch. And we again did an EEG study where we gave people laser pinpricks, and they are good because they're only 4 millisecond quick laser pulses, feels like kind of hot fat spattering out of a pan. And what we can measure is the brain's response directly to that pinprick. And you get two kind of brain evoked potentials. One is a very early N1 component, which just indexes, ooh, something's happened, essentially. And then there's N2, P2 potential, which is said to index the conscious experience of pain. And greater amplitudes basically denote greater subjective pain report as well. There's a correlation between the two. So briefly, what we found in acute pain is that this slow, gentle stroking touch elicited the smallest evoked potential after the pinprick. So showed a kind of dampening of the pain response when people were being gently stroked by their partner. And what we said that might do is essentially, if we think back to our brain model that I presented to you earlier, touch may reduce kind of how salient that incoming sensory input is. So it can signal the presence of an active, socially supportive environment, that top bit, on the pain experience. Now, in chronic pain, there's not a huge amount of consensus about how effective touch is processed or impacts pain experience. There have been a lot of studies administering slow, gentle stroking touch, but they often use different comparison groups and different touch speeds. And so there are sort of mixed results about how this kind of touch is perceived in chronic pain. But really importantly, they rarely consider people's preferences for social support, their closeness, again, the relational context, the closeness to the person touching, or fluctuations in ongoing pain. Because we know that if you have a chronic pain, somebody with chronic pain come into the lab on one day might be quite different to them coming in on another day. And that makes research a little bit more tricky. So again, we took this to our public and patient involvement panel, and we asked them about touch and touch in their lives, and had some really interesting qualitative insights. And in particular, this idea of high or low pain. People said that timing is a big issue. They wouldn't like to have any touch on bad pain days, and they just want to actually be left alone because touch can interfere with other kind of cognitive strategies people are using to deal with pain. And so the consensus was there's a sort of sweet spot for touch only when when in not too much pain. There was also kind of some interesting feedback on being together but not necessarily touching. So this links back to the personal space idea. You could be in their personal space but perhaps not actually touching. And then this is an important one. So in chronic pain research, we often look at pain as the outcome, but our public and patient involvement group really highlighted that there are lots of other key outcomes that are important to them, like getting to sleep, staying asleep, reducing fatigue, and also the nausea that comes with fatigue. So I think it would be really useful to study outcomes that are not a pain intensity rating or pain unpleasantness rating. So what we did, the last study that I'll show you, is recruited 56 participants with chronic pain and 45 healthy comparison participants. Everybody was currently in a relationship because we wanted to get at that romantic relationship in this study. And we asked them to watch touch videos. And here again, we have some social neuroscientific evidence to suggest that vicarious touch, so seeing touch, actually activates very similar brain regions to experiencing first-hand touch. So that viewing videos is not a bad proxy if you can't do a lab study where you bring people in and touch them firsthand. So they rated the touch videos for various different things, and importantly, we got them to think about when they're in high pain versus when they're, I mean, not in pain was only salient for the healthy comparison. It was kind of less pain for people in the chronic pain condition. And we got them to self-report on how they perceive their close social relationships and their touch attitudes and things like that. And if anybody's interested, we've developed a questionnaire to get at these sort of things. It's called the RASP. It's been around for a while now, and it indexes people's responses and attitudes to support during pain from loved ones, but also healthcare professionals. So if anyone is interested in using that scale, it's all free, publicly available. Please ask me. I'd be happy to help. So what we found essentially is that our chronic pain group behaved reported very similar things to our healthy comparison group. So you can see that everybody found the slow touch more pleasant than the fast touch. There was some evidence that people in chronic pain found the fast touch less pleasant than our healthy comparison group, which kind of makes sense. That liking for touch, so how much people wanted that or liked that sort of touch, was predicted by their general preferences for partner support. So people who endorsed turning to their partner a lot for support during pain also reported liking touch more. Similarly, people who had more positive attitudes to intimate touch also reported liking touch more. And the distraction was another one. So people who use distraction a lot as a technique also like touch more, because of course, although it's a social thing, can also be distracting. And open questions that we have here are really, well, what kind of do different types of touch mean to people with chronic pain? We haven't really explored that. I think there's a piece of work in there. We've done touch meaning studies in the general population. So where we find robustly that this slow, gentle stroking touch is associated with communicating intentions of support, of love. It's also sometimes related to arousal and desire. So we've looked at touch meaning in the general population, but we need to explore that more in chronic pain. And so, essentially, do these types of touch also communicate love and support in chronic pain? So those are some open questions that we're looking at there. And of course, a unique sort of feature in chronic pain that we need to consider are the kind of sensory issues like allodynia that you don't have when we've looked at this in the general population. So just to recap, we've considered some theories and paradigms of social neuroscience and how we can look to social neuroscience for breaking down some quite complicated constructs such as empathy. I've given you 3 different flavors of research, from more distal to more proximal. And what we seem to find is that there is a tendency to interpret kind of potentially empathy related cues more negatively in fibromyalgia, but we haven't found any kind of group differences in terms of peripersonal space or touch, I would add, as well. I took that out, sorry, because this is BNA, and I'm not going to have time to talk about touch at the BNA. So there are plenty of open questions and ways in which neuroscientific approaches can enrich our understanding of the experience of these interpersonal interactions and chronic pain. And even if you're not a social neuroscientist, a lot of these theories, like social baseline theory, are actually really accessible and a really nice way of framing thinking around these complex social dynamics that we often see in the lab and in real life. So thank you very much for your attention, and I'm going to stop sharing so that I can see you all again. Thank you.
Thank you, Charlotte. Great overview. And I think you said at the beginning about going to go over stuff that's so complex, but the way you present makes it so clear and accessible. So thank you.
Thank you.
Have we got any questions for Charlotte? David?
John, I'll get the ball rolling then, Charlotte. So as always, I really enjoyed the social neuroscience work that you present. I think it's a really interesting combination of the lab-based and kind of mechanisms understanding without losing sight of clinical and kind of real world implications, which I think is always a challenging thread to walk. I wonder whether or not you have any thoughts as far as the role that our social kind of place holds beyond the kind of close relationships that we might have. So, parents, loved ones, close friends, and healthcare providers for a start, all likely know about the conditions that that we might be experiencing and have an interest in our health outcomes. Is there any work that looks at the role that our socialization with colleagues, kind of mates, the person kind of that we see regularly but don't have a close relationship with might have on on some of those feelings?
I know some acute pain work that varied these kind of different relationships a bit more systematically. So there's a nice study that's just come out last year that compared the presence of a friend to the presence of a dog on acute pain experience. The dog had the greatest pain relieving effects because they were deemed to be the least judgmental and most, I mean, anyone who has a dog, no, they just love you. You can't get much more pro-social than that. So there's some, in acute pain, people have varied those different relationships a bit more systematically because it's easier to do that in a lab context. In relation to chronic pain, there's a lot of qualitative literature where people have explored, for example, how people's sense of identity changes in the workplace following the development of chronic pain, things like that. So there is, I know, quite a lot of qualitative information there. I don't know of any great amount of work in terms of work colleagues, for example, or employers on pain outcomes. Or it's not some. The reason I picked these two is not just because I researched them, but because they are also the most heavily researched. I think there's more. It's the same reason why I don't look at friends as much. There's a lot of variability within those categories. So we all have friends who we consider closer than family, but we also have friends who are more like loose acquaintances. So it becomes a bit tricky to untangle some of these things a bit more, and same in a work context. So qualitatively, there are interesting insights. Experimentally or kind of neuroscientifically, I don't think there really are.
Thank you.
But I'll have another look. Yeah. It's interesting because some things. Oh, sorry, go on.
I was just thinking around sort of the work and employers would be interesting because a lot of like the patients struggle with feeling not understood. Yeah. And that's true what Dave's saying, that an employer would have even less of an idea about chronic pain certainly than a healthcare professional and family. I mean, I would say that family and friends sometimes don't really have a very good understanding of chronic pain, so that's an assumption there. But certainly employers are, it's more tricky. It would be a really interesting thing to look at for sure. I'd be good at avenue for research. Yeah.
I mean, I wonder both within potentially that literature, but also maybe more, the areas where there is more data, that the role that how visible that injury or how visible that pain is might kind of play in people's kind of perceptions. If someone looks sick, we usually give them more freedom to kind of be sick. If someone looks kind of healthy but is telling us that they're fatigued and struggling, then often people are far less sympathetic.
So I tend to look at mechanisms that are more dyadic and more interpersonal, but some of the social level things come into play there. So for example, you'll start getting to looking at social models of disability versus biomedical models of disability and so on. So if you look at those more kind of intergroup level or societal level effects, there will be different frameworks to look at and apply. So that would be really interesting to do as well. Thank you.
Thank you. So is there any other questions for Charlotte? One of the things I was kind of thinking about, and I missed Maria's talk actually last month, is kind of thinking, where do you see this sort of going next into influencing practice?
I think Maria would actually be the best person to answer. Don't know if you want to take that one.
I don't know whether it was asked sort of at Maria's talk or not.
I think it was. Maria, if you're there, do you want to take that one?
Yeah, I'm here. Yeah, it was one of the questions that came out after my talk. Yeah, and basically we were discussing how difficult it can be to teach or to create some guidelines to make practitioners or clinicians feel more empathy. But our aim is to implement all this knowledge from our studies to create some useful guidelines to make healthcare professionals communicate this empathy in a better way. So basically, there will be like communication advices or evidence-based instructions to improve this healthcare to fibromyalgia and other chronic pain conditions as well.
So in acute pain, for example, the review I mentioned at the very beginning, we found that the most pain relieving social interactions are unequivocally positive and pro-socially intentioned. So if any ambiguity, if you can avoid that, and it's better to be, and by positive I don't mean toxic positivity, I mean a pro-social stance, right? So in acute pain, that's been well demonstrated, but I think what this shows us from Maria's initial data in the interpretation bias study is that actually ambiguity may be interpreted negatively, so you're better off communicating very clearly and as unequivocally pro-socially intentioned as possible. So that's sort of, we have different kind of strands that we're weaving together to produce a bit of guidance. And I think that study was born out of thinking, well, perhaps healthcare professionals are being mega empathic and it's not being received in some way. And so that was that kind of starting point there is, well, how do people with fibromyalgia specifically, decode those sort of cues in healthcare encounters? And once we know that, then the next step is to systematically vary cues like that and see what the impact on pain and distress within ethical limits, obviously, in small doses, to be able to kind of look at those causal links.
Okay, thank you. Any other questions or comments? No. Okay. Right. Well, thank you. Sorry.
No, I was just going to extend an invitation. If anyone ever wants to come and see our social neuroscience lab, you are more than welcome to. We are very happy to show people our EEG and FNIR setups, our laser equipment, etc. So just putting it out there in case anyone's interested. Please do reach out. I might
take the opportunity while I'm in there. Thank you.
Yes, definitely. Thank you.
Okay. Thank you, and I hope it goes well on Tuesday.
Thank you very much. Thanks everyone for your time.
Thank you. Bye-bye. Bye.
Take care. Bye.